75-year-old man suffering from left-sided weakness is brought to the emergency department by his son. The symptoms started suddenly 2 hours ago. Patient is a known hypertensive who is inconsistently compliant with his two antihypertensive medications. He is also a heavy smoker with a 40-pack a year history. Physical examination shows the man in mild distress. Vital signs include blood pressure 140/95, pulse 89, oxygen saturation 98% on rooming. Neurological examination shows left-sided hemiparesis with no sensory, cognitive, or brainstem involved abnormalities. CT scan of the head without IV contrast shows right-sided ischemic infarct. What other finding is most likely to develop in this patient as his condition progresses? Options: classic paresis, loss of deep tendon reflexes, fasciculations, muscle atrophy, and positive Babinski sign. So first of all, this is a right-sided ischemic infarct. As the CT scan shows, patient has pure motor loss, which we what we call hemiparesis, and he has left hemiparesis. When we have motor neurons involved, we have to know that we have a couple types of motors, right? We have upper motor neurons and we have lower motor neurons. Upper motor neuron is going to start at your cortex, your cerebrum, basically, and it's going to start at the precentral gyrus in the primary motor cortex, what we call the Brodmann area of 4. Even if you don't remember, I think it's going to be okay. But just remember that your motor cortex is your precentral gyrus. Okay, that's your primary motor cortex. From there, we have these are the UMN. They start in the precentral gyrus. They pass through the posterior limb of the internal capsule, through the cerebral peduncle, going down into the spinal cord through the medulla. Also remember the decussate in the medulla. I think 90% of your UMNs will decussate, and we call them pyramids in the medulla. They have particular structure. If you dissect the medulla into half, you're going to see those pyramids. Okay, so they have the pyramidal decussation in the medulla going down into the spine. They make up what we call the lateral corticospinal tract. The rest of them that didn't decussate is going to make up the anterior corticospinal tract. As the name implies, coming from the cortex going down into the spine, corticospinal tract. Lateral because it's on the lateral side, anterior is because in the anterior side of the spinal cord. Anatomy is easy if you remember your words and just make sure where everything is positioned. It will be easy for you to remember the tracks as well. Okay. Now, when they go down into the spinal cord, they are going to synapse with the ventral horn. Okay, ventral horn of the spinal cord, and that's where the element starts. What we call the lower motor. The lower motor neuron are going to start from there, and they are going to innervate wherever your muscles or whatever glands or whatever they want to do. They're going to go over there, especially muscles, of course, right? Because it's going to be the motor neurons. So whenever you have a UMN lesion, you can say you have a central lesion. An element lesion, you can say you have a spinal cord lesion. But also remember, your corticospinal tracts are still your UMN in your spinal cord. So even your UMN can get damaged when you have spinal cord. It depends on the level where it is. So when you have UMN lesion, what we have is what we call positive Babinski sign, which is when you stroke your foot and if your toes are kind of fanning, that is called a positive Babinski sign. Normal, you're going to have a flexion, what we call plantar flexion. This Babinski is actually normal until the age of 18 months of age, and it's going to go away. So it's abnormal when it's seen in an adult. So if you see it in this patient, 75-year-old man, it's going to be abnormal. And you can say that he has a UMN. UMN will also cause hypertonia or spastic paresis. It's also going to cause hyperreflexia. And it's also called what we call diffuse atrophy because your elements still can function a little bit because it's coming from your spinal cord. But without your element, you cannot innervate your nerves, right? And so because your element, because you have UMN injury, you don't have signals coming from your cortex to your spinal cord. It's your spinal cord that just directly senses and causes those reflexes sometimes, right? Those deep tendon reflexes. So some of the deep tendon reflexes can still work when you have UMN injury because it's just gonna go around your spinal cord. It also depends on where your UMN injury is. UMN means the upper motor neuron injury is. If it's below your decussation, then you're going to have the same side of paralysis. If it's going to be after, above your decussation, you're going to have contralateral paralysis. When you draw these pathways, draw based on the whole neurons where they go, make a cut right there and make sure you remember that that is above your decussation, and so it's going to cause contralateral paralysis. Scan shows has, because his CT scan shows right-sided ischemic infarct and he has left-sided weakness. So he has contralateral paralysis. That's why we are assuming his UMNs are affected, and that's why he's going to have positive Babinski sign. The rest of the options that they mentioned here is more likely going to be the elements, because elements are the one that causes loss of deep tendency, the one that causes paralysis, tendon reflexes, fasciculations, and your muscle atrophy. All of these be your elements. So rest of the other options, they all are signs of LMN. If you have LMN lesions, it's going to cause flaccid paralysis, loss of deep tendon reflexes, fasciculations, you may see fibrillations also, those are the other words that we use, and also muscle atrophy. All of these are going to be in your LMN lesion.
Thanks for watching. Please give a thumbs up and subscribe for more.